Good morning, everyone. Welcome to Pediatric Grand Rounds. The distinct honor of introducing our speaker this morning, Dr. Nancy Free, who, as you all know, is one of our own. Dr. Free is clinical professor in our department and also medical director of Child's Voice, as well as medical director of the Foster Care Clinic. Dr. Free obtained her bachelor's degree in liberal arts from Loyola University of the South and her Doctor of Osteopathy from the University of North Texas. She then completed a rotating internship in Tulsa, Oklahoma, and her residency in pediatrics in Columbus, Ohio. Dr. Free has been in practice in Sioux Falls since 1992, excuse me, and at Child's Voice since 2004. I think many of us have had the honor of working with Dr. Free, and she works in the area of child abuse, which for, again, many of us is a difficult area to work in. We are very grateful to have her here to provide clinical services for these children and families, as well as the education that she provides to our learners as well as her colleagues. Today, Dr. Free will be speaking to us about child sexual abuse. Please help me welcome Dr. Nancy Free.
Good morning, and thank you. My voice is kind of scratchy, and sometimes I talk too fast. So if I am difficult to understand, tell me to slow down and move back to the microphone. All right. Today we're going to talk about child sexual abuse in 2017. Some of the information that I'm going to present is new. Some of it is just represents nuances of where we've been. Much of it is things that have been around for a long time. But I think it's an important topic to present for all of us who take care of children and families. Child sexual abuse is a very important topic, and by increasing awareness and the ability to respond, we help not just the children and families in our practices, but we're able to increase awareness in the general public, which will ultimately help all children and lessen their likelihood of victimization. I have nothing to disclose. So today we're going to talk about risk factors, understanding outcomes, talk a little bit about resilience and prevention. You have to have a definition. This is from the American Academy of Peds. So sexual abuse involves a child or an adolescent engaged in sexual activities for which they either cannot understand, that are developmentally inappropriate, or which the child cannot give either informed consent or sometimes by virtue of age cannot give consent, and or there's a violation of the legal or social taboos of society. What does child sexual abuse include? It includes contact sexual acts, so oral, genital, and anal contact, or touching the child, or having the child touch the perpetrator. There are non-contact acts, as well as exploitation. Child pornography has exploded over the past 10-15 years, in large part because of the internet. Victimization by child pornography used to be primarily in the production and in the limited sharing of still photographs. But now we live in a digital age, and children who are victims of child porn really suffer re-victimization because that pornography is out there and cannot be pulled back in. Our older kids who understand that there are pictures out there really are traumatized repeatedly. Child sexual abuse needs to be differentiated from normal sexual behaviors of childhood, because all children do things that are sexual. But what are normal sexual behaviors? First of all, there's developmental symmetry between participants. And so it's 2 3-year-olds, 2 8-year-olds. Or it could be a developmentally delayed 7-year-old and a 3-year-old. But there's developmental symmetry. There's no coercion. And even if there's developmental symmetry and no coercion, we kind of draw a line if there's intrusive acts. Sometimes children do that, and we don't know how they learned about it, but we consider it not okay. Problem sexual behaviors. There's that developmental asymmetry, sometimes some degree of coercion, intrusive acts involving animals, and some children just have excessive sexualized behaviors that can't be redirected. So the child who touches themselves and prefers to stay in their bedroom, because if you're going to touch your private spots, you have to do it in private, and they prefer to stay in their bedroom instead of going out and playing. Talk a little bit about numbers. The standard phrase is 1 in 4 girls, 1 in 6 boys. Numbers, now maybe we're stretching it to 1 in 10, but I think sometimes boys don't disclose as readily. We also know that most children don't disclose acutely, and somewhere between 5 and 25 to 30% of adults report being sexually abused as children, and in that cohort, up to 50% of those adults never disclosed as children. So we don't know, but we do know that it's very, very common. And if you combine the incidence of childhood cancers, juvenile onset diabetes, and congenital heart disease, put those in one pot, the pot containing child sexual abuse is going to be bigger. Who is victimized? It can be anybody from birth to age 18. At Child's Voice, we see children from birth to age 18. We will also evaluate developmentally delayed adults, because sometimes their evaluation is best accomplished by people who can really relate to their developmental status. Teens have the highest rate of sexual assault, not just within the group of children, but across the board. When you look at sexual assault numbers from birth to age 200, teens are the highest, have the highest rate of victimization. And again, we have to remember that the age of victimization is often not the age at which children disclose. What places a child at risk? First and foremost, lack of a protective parent. And so sometimes that's a parent who doesn't pay attention to who he or she entrusts their children to. Sometimes it's a parent who can't be present because of substance abuse or mental health issues. Children who have poor parent-child relationships are at higher risk of being victimized because they're more susceptible to the grooming process. Grooming involves a process in which it's easier to access a victim. Sometimes it involves simply being kind to a child, buying presents, making that child feel special. So whether it's a small child or a teenager, kids who don't have that close relationship are more vulnerable. If the parents have a poor relationship, those children are more vulnerable. And that non-biologically related male in the home, really increases the risk for children. And so whether that's a boyfriend or whether it's just someone sharing the rent, if that male is not biologically related to the child, including a stepfather, those kinds of things, those children are at higher risk. Children who have been victimized previously are at higher risk of re-victimization. That makes sense. At first you think, well, why is that? If you've been desensitized to an act, if you maybe don't understand that this is not the norm, that perhaps this doesn't happen to everyone, then you're going to be more easily victimized again. And then our children with physical disabilities are at higher risk of victimization. So who does this? Sorry, there's way too many words on this slide. But really, most offenders are known to the child and the family. Most offenders have ingratiated themselves into the family unit. There's someone that is respected by the child and the family many, many times. So whether it's a parent, a caregiver, or if you think about the Sandusky case, this was a man who was a classic offender. He befriended vulnerable families who had small boys or big boys. He initially presented himself as Mr. Wonderful. He said, "Oh, I know you're strapped. Let me help purchase this for your child. Let me have your child. Let me give you a break in time. Your child can come spend time with me." Just a classic approach to gaining access to children. Most sexual offenders are male. But when I talk about victims, when I talk about perpetrators, whatever gender I use, just realize that can be switched, because victims are both male and female. Perpetrators are both male and female. When we look at the history for perpetrators, most of them have grown up in very extremely dysfunctional environments, with chaos, violence, and just general disorganization, with poor emotional connectivity in the family. So we're going to talk a little bit about the difference between a pedophile and a situational molester. Most child sexual abuse is perpetrated by situational molesters. And so that's someone who has access to children, oftentimes a family member, someone living in the home, a coach, a teacher, someone serving in a youth serving organization, anyone who has easy access to children. And oftentimes it's thought of as a crime of opportunity. Our preferential child molester is what we think of as a pedophile. They are almost exclusively involved sexually with children. Their interest begins in adolescence. Pedophiles tend to have a great number of victims over a lifetime. And when you look at their life choices, they tend to spend the majority of their social time with children or individuals younger than they are. And they often use the internet for trading information, not just pornography, but methods to entice children, where children are located, those kinds of things. When we look at pedophiles, only 30% were sexually abused as children. Because we think, every child who's sexually abused is at risk of becoming a pedophile. Most pedophiles were not sexually abused as children, but most pedophiles have started their abuse as children. And up to 40% of sexual crimes against children are committed by juveniles. This is critically important for us who work with children, both to understand the risk for victimization by juveniles, but to recognize that juvenile who needs intervention as a juvenile, so that we can protect him from hurting other people. Most sex offenders have between 1 and 9 victims, and that is most often your situational molester. But serial child molesters can have as many as 400 or more victims. Adolescent males perpetrate about 20% of assaults and up to half of child molestations. Some of these kids start very young. We don't like to talk about a perp being under 10 or being under 12, but when you look at their actions, they are perpetrating actions, not just problem sexual behaviors. But as you can see, most of this starts very early, and the majority of the offenders as juveniles are males. Who do juveniles victimize? Family members and acquaintances, and sometimes we don't know who they victimize. Where does this happen? And this is interesting. It happens most often in the home, and parents, when there's intrafamilial abuse, are horrified. This couldn't be so. I'm there all the time. You sleep sometimes as a parent, and oftentimes children while we're taking care of our house, are often in different parts of the house, and we don't have eye contact with them all the time. It happens a lot in schools. It happens a lot on school buses. Unfortunately, we've had, a child's voice is rather anecdotal, but many cases over the past couple of years where kids have been touched on school buses by older children. Why do they offend? Really, there's many reasons. But sometimes it's sexual curiosity. Sometimes it's children who have no respect for others, who violate the rights of other people in many ways. Sometimes it's children who have mental health issues. Sometimes it is a true sexual gratification that is directed to children. Sometimes the behavior is compulsive, but sometimes it's very impulsive. Our juveniles by nature are impulsive, and this is one other area in which they can do impulsive things that are not okay. Children who have lower levels of family support are more likely to engage in sexual offenses. Sometimes it's those children with the personalities that are very forceful, that get pleasure from harming others, are more likely to offend. And sometimes it's the children who are very submissive, who, unless they have a very close relationship with someone, they don't have any confidence. If a child is physically abused, that dramatically increases their risk of becoming a sexual offender, as opposed to a child who's sexually abused. And again, this makes sense. If a child has fewer protective factors, including emotional support and social skills, they're more likely to be affected by their early abusive experiences, and that increases their risk of becoming sexual offenders. When we look at juvenile offenses more often involve more than one perpetrator, whereas adult sexual offenses on children most often involve a single perpetrator with a child or children. Not always, but because it's more common to have more than one offender as juveniles, there's a question, is there some sort of peer pressure involved in this as well? Now we're going to talk about, what does this look like? How does it present? Sometimes it's because someone says something. Sometimes it's because someone sees something. Sometimes it's because we're worried about, why is this child behaving this way? Sometimes we forget to think about it when a child has physical complaints. Sometimes they're very direct physical complaints of genital complaints about genital findings, those things. But sometimes it's that child who presents with unexplained headaches, those kinds of things, or unexplained emotional symptoms. We've got to remember to include this on our differential. And we have to remember that children often don't tell about the abuse right away, and children usually know their perp well. What kind of behaviors do we see? Sometimes children have very dramatic changes in their behavior. They become quite withdrawn from both their family and their friends. Sometimes they'll spend a lot of time just exclusively with their perp. Sometimes children become very aggressive. Sometimes their trauma can really look almost identical to attention deficit issues. And so anytime a child is evaluated for ADHD, please include trauma, including sexual abuse, on that differential. Some children will have sexualized behaviors that make us worry about sexual abuse. But it's really critically important to remember that sometimes children will have no outward sign that they are being sexually abused. But it's very interesting because I've had conversations with different people who say, just because I look normal on the outside doesn't mean that I am not suffering from trauma. And so those people that they talk about as adults say, I could really separate my abuse or compartmentalize it when I was a child. And so I looked very normal. I was that super achiever. And so from the outside, they can look absolutely normal, but we have to remember that they deserve help as well. Because on the inside, They all say, I'm not okay. No single symptom or psychiatric syndrome will tell us whether or not a child has been abused. That's critically important. In court, I'm asked all the time, well, does a child do this, this, or this, or this? No, they don't. Well, does that mean they're not abused? Absolutely not. You know, if they did all of those things, that still wouldn't tell me that they were abused. And so we look at symptoms because we want to address them. We look at risk factors because we want to remove them. But all the risk factors, all the symptoms, all the signs, really we have to put in context of that bigger picture, because individually none of them will tell us what has or has not happened. The Adams criteria were first generated in 2007 by a group of child abuse pediatricians, leaders in the field, and they were updated in 2008, then again in 2015. These criteria address really the evaluation of children who are possible victims in each of these categories. And so these next slides are all going to be talking about the Adams criteria. When we talk about indications for emergency evaluation, really we have to look at safety, we have to look at injury, suicidal ideation, and we have to remember that human trafficking is a form of sexual abuse. We have to look at timing. When did things last happen? And so we talk about 72 hours. That has been traditional. In the state of South Dakota, for a child who is prepubertal, that 72-hour window is generally our cutoff. For our postpubertal females, we're looking at out to about 120 hours. And that is because our testing of forensic evidence has become better, and there's actually sometimes we find things that far out. We'll talk more about that in a minute. So if the child has medical needs, including treatment for exposure to sexually transmitted infections, need for dealing with possible pregnancy, and post-exposure prophylaxis for HIV as well, we want to see those children right away. When do we need to see children sooner than later? But it doesn't have to be the middle of the night or the first thing in the morning. If something has happened within the last couple of weeks and all those other criteria are met, the child is safe, they don't have urgent needs for medical treatment, then we can wait until daylight and let everybody get a little bit of sleep. What is non-urgent? So if we have a disclosure by a child or sexualized behaviors, but it's been remote, then we can do that at a time that best meets the needs of the child as well as the multidisciplinary team that might be involved in the evaluation. And so if a child presents to your office and is talking about something that happened last month or last year, yes, let's get that ball rolling, but it doesn't have to be today as far as coming to child's voice or talking extensively with multidisciplinary members. When do we need to see children back? We see children back anytime that we find injury to document healing. We see children back to repeat STI testing. We also see children back if they were evaluated by someone outside who is not sure or does not have documented expertise, because it's very common to overcall findings in the anogenital region if you're not familiar with detailed genital examinations. As far as timing, the other thing is that window is the outside limit. Truly, the sooner a child is seen for collection of forensic evidence, the better. And so don't say, oh, we're at day 1, we can wait until day 3. No, we want to see that child right away. That child needs to have specimens collected, so that 72 and 120 hours is the outside limit. Some things that have changed in these Adams criteria is interpreting medical findings. The categories have remained the same. So we have the category of normal findings seen in children who are not abused. Those include things like normal variations in hymens. On a side note, every female in whom there is no concern for ambiguous genitalia has a hymen. And sometimes it may be difficult to see or appreciate, especially in the newborn period, if things are swollen or if there's a lot of estrogen effect. Sometimes it's difficult to identify if a child is uncooperative with the exam, but every female who does not have ambiguous genitalia has a hymen. There are findings commonly caused by medical conditions other than trauma or sexual abuse, and sometimes we mistake things for abuse. There are things that the experts say we're not sure, and so it's just important to know that there are some findings with no expert consensus, but if those findings are present, can support a disclosure of penetration. There are findings that are caused by trauma or sexual contact, and so if there's acute trauma to the external genital and anal tissues, the labia majora, the posterior fourchette, the perianal tissues, that is indicative of trauma. There can be healing injuries to those same tissues. There can be injuries to the hymen, to the anal tissues, all of which tell us there's been trauma. Injury to the hymen tells us there's been penetrating trauma, most likely to be sexual in nature, but not always, and that's why history is critical. If we have a child who gives a history of impaling themselves on a bedpost or a bathroom plunger or those kinds of things, the multidisciplinary team needs to go out and investigate and say, is there a bedpost, is there a plunger, are those kinds of things present in the environment to corroborate that history given by a caregiver. What has a child been able to say about what has happened to them? And so we're very careful about what we say when we're talking about diagnosing sexual abuse. I can say a finding is consistent with penetrating trauma, and that penetrating object could be a penis, it could be something else, it could have been something unrelated to sexual abuse, but most often we're going to have that history. We should have a good history, if it's not sexual abuse, of where that trauma came from. Two things are diagnostic of sexual contact. One is pregnancy, and the other is finding semen on the child's body. And then recommendations, we're going to go through those in a little bit. But basically, what do I do if a child presents to my office and I'm concerned about sexual abuse? First of all, we have to listen. We want to get minimal facts. We're going to talk a little bit about disclosures and questioning. We have to thank this child for disclosing and tell them we will help them. Something I learned in the last few years is not to tell a child, I believe you. Because if I say that to a child, that presents the opportunity that someone may not believe them. And if that's not part of their growing process, they're shocked that someone may not believe them. And so I will help you, thank you for telling me this, but not I believe you, unless the child has said, so-and-so doesn't believe me, or so-and-so said no one will believe me. What do we need to do when we address sexual abuse in the office setting? First of all, address safety. We need to make a report. We have to evaluate that child's mental health. How are they doing? Are they suicidal? Are they homicidal? What is the need for physical examination in your office if they're going on for further care to a child advocacy center? Certainly if a child there's concerns about bleeding, instability, that child needs an anogenital exam to be sure they're safe to transport or to wait for that exam. And then we talked about the need for forensic evidence collection. When kids are telling us things, we need to listen. We need to listen with poker faces, even though our heart rate may jump to 200 and we're feeling kind of queasy. We just need to keep a calm, very neutral face and say, yes, help me understand. We also have to remember that sexual talk or play is often a symptom of something happening, and so we should not punish children for that. We can redirect it and say, help me understand where you learned that, and that's really Private parts are private. We should not be touching other people or talking with peers about those things. If you have questions, please, you can ask me. But we have to remember it could be a symptom. We have to understand, where did that child learn this? If a child discloses in your office, be sure you tell the child it's okay to talk with adults about this, and try not to jump to, you know what, don't tell me anymore, I have somebody else for you to talk to, because that makes the child nervous about, well, should I be telling them about this? As soon as you can, separate the child older than 3 from the parent to get further information from the child if you need to. Oftentimes that parent has already heard the disclosure, and you can get every bit of information you need to make a report and a referral from their caregiver. If it's a new patient and they're coming to talk to you about their abuse, establish a little bit of rapport. What do you like? What do you don't like? Who do you live with? How's school? Those kinds of things, instead of jumping straight to their sexual abuse scenario, because sometimes kids need to be a little more comfortable before they're willing to spill. Like children know, it's your job to keep kids healthy, and it's okay to talk about uncomfortable topics in this office. Always ask open-ended questions. Try to not ask direct questions, and please never include an answer in your question. So, who hurt you? Did daddy hurt you? Did mommy hurt you? Who touched you? We don't know if a child's been touched. So very open-ended, tell me about that. We're lousy as providers of healthcare to children and being open-ended because we're in a hurry. And if you ask an open-ended question, it could take a long time to get the information you need. We never force children to talk, because that could re-victimize a child. If the child says a little bit and then you're worried, it's not the job of any of us to make a child talk. We need to let a child talk when they're ready. We also should not reward a child for talking or bribe them to talk, because that really muddies things up. Let a child say what they can say, and then that's okay. When we talk to children as medical people, we are not forensic interviewers. We are taking a medical history, and so we need to remember that, because most of the time the child's going to talk to someone who's going to take a forensic history. For children, hopefully that happens at a child advocacy center with a forensic interviewer. Sometimes it's with law enforcement or child protection, but regardless, we are not interviewers, we are medical people. But we need to record what we hear objectively, and so if a child says something or behaves in a certain way, describe the behavior. The child is agitated. We have to say the child appears agitated and put why, because then that's going to be much more clear down the road as far as what was happening in the office. We have to remember that children often don't disclose. 1/3 up to 1/2 of adults sexually abused as children never told during childhood. Why don't kids tell? We have parents come in who say, this couldn't have happened. I know she would have told me. I know he would have told me. Actually, children often don't tell, and they often don't tell the person who loves them most, because they know it's gonna ramp things up. They don't want to upset their caregiver. They've been told that caregiver's not going to believe, and so it's normal for children not to tell. Sometimes children don't have the language skills to describe the sexual act that took place. And so how can they tell about it if they don't know what it is? Single events by an unknown perp are much more likely to be talked about, as opposed to something that is chronic and ongoing. The other thing that sometimes inhibits disclosure is the physiologic response to sexual abuse, because sometimes the things that happen to children evoke a pleasurable physiologic response, and that then children are very confused about, well, if I liked it, maybe it's my fault. And so that makes it more difficult for them to tell. If the perpetrator is in the family or a close family friend, that makes it harder for children to tell, both from the standpoint of, will I be believed, but also because they have mixed emotions about this person. It is very common for a child to love their perp, but not like what's happening once they come to understand that it's not okay. Fear is the most common reason for children not to tell. Disclosure is a process. Most children don't start telling and tell everything all at once, especially if it's something that's happened multiple times over time. The support that a child receives after disclosure is critical for the disclosure process. It affects recantation rates, but most importantly, it impacts healing or the ability to heal. Disclosures can be intentional. So a child has decided, I'm going to tell, for a whole host of reasons. Sometimes they're tired of it, sometimes they're safe, the perpetrator's moved on, sometimes they're worried about another sibling, sometimes it's accidental. So if sexual abuse is presented as a game, that child may talk about this game, and all of a sudden an adult says, oh, tell me more about that game, and they then describe sexual abuse. Again, most disclosures delayed. When we talk about consistencies and inconsistencies in disclosures, we have to remember that sometimes we ask lousy questions, or sometimes we just ask different questions, and so the answer is going to be different. That doesn't mean that the child is inconsistent. In recantation, just because a child recants doesn't mean nothing happened. Oftentimes it means that the child has said, you know what, this is not a safe time or place to tell. Who do kids tell? Teenagers tell their friends because that's who they talk to. Younger kids talk more to their parents, so sometimes they'll tell their parents first. What about the physical exam? Physical exam, the physical evaluation, is first and foremost the provision of medical care. Again, we are not investigators. We are looking to the needs of the child. We address that child in a comprehensive fashion, in a thoughtful, thorough, and child-friendly manner. We should never do just a genital exam. I mean, that would be just awful. And so we really do a head-to-toe exam, whether you're in the office and you need to see if a child is bleeding before you refer them. Please at least listen to their heart and look at their ears, and not just go straight to their genitals, because then that is another type of re-victimization. Why do we need to do a complete exam? Because sometimes there's other injuries that we would miss if we didn't. Sometimes that complete exam is going to give us information that tells us this is actually not sexual abuse, but a medical condition. And sometimes children have conditions completely unrelated to abuse that we need to diagnose and treat or refer. Children who are sexually abused often come from a demographic that does not get routine medical care. They don't get well child exams. Many times their medical care is received in acute care clinics and emergency departments, and so that comprehensive exam by someone trained to work with children sometimes uncovers lots of things that need to be addressed. Important to remember that the vast majority of physical exams for sexual abuse, anogenital exams, are normal, even if there's a history of penetration. Why is that? Because sometimes whatever happened doesn't injure tissues, and if you don't injure tissues, you're going to have a normal exam. Sometimes, because children just usually don't disclose acutely, whatever has happened has healed. These tissues are designed to heal. They have a great blood supply. Mucosal injury heals very, very quickly, oftentimes in a matter of 24 to 48 hours. And a corollary to that is if you burn your mouth with hot coffee or pizza, first day it stings like the dickens, the next day it's a little bit sore, third day it's gone. And so mucous membranes heal quickly. The female hymen changes dramatically from pre-pubertal, from Tanner 1 to Tanner 5. And so those changes with puberty goes from a thin, translucent structure to something that is thicker and more redundant, can mask any injuries that were present prior to puberty. And so lots and lots of reasons why anogenital exams can be normal. When you think about some of the stools that we see children pass, they may develop a fissure, but that fissure is going to heal again very, very quickly. And so most children who have rectal penetration will have normal exams unless they're examined acutely. And oftentimes, even if they're examined acutely, depending on what the penetrating object is, will have normal exams. All children are offered an exam regardless of their disclosure. Children should never be forced to have an exam. We don't sedate children for exams unless they have to go to the operating room because we are concerned that they might have an injury that needs repair. Again, this population is often medically underserved. In our office, we do colposcopy, which is external. It is not vaginal colposcopy. And really what that does is provide us a magnified image of the anogenital structures, and so we're more easily able to identify injury. This exam is not traumatic. We don't hold children down kicking and screaming. If they, I'm going to say it's, I've looked at their eyes and their ears and checked their abdomens, saying that the next part is for me to look at your private parts. Is that okay with you? And if the child says no, we'll explore that a little bit. Why? Because it's embarrassing. I get that. Why? Because you're worried about something. How can we best address that? Or if I just don't want to do it, and then we don't have to. But I want you to come back either here or to your regular provider because someone needs to look. Just like we check your heart and your lungs and you're not having any symptoms there, sometimes you can have issues with your private parts that need to be looked at. And again, even if it's not an acute event, children need and deserve a genital exam because these children oftentimes feel like damaged goods. And so if we can say to them, all those things you talked about, those things you said that hurt, your body is normal. They're like, really? And some of those kids really want to look and see, and we'll show them. The other thing is if we see an injury, we are very careful to explain to the child, this is just like a little scrape on your hand. It's going to heal completely. We have those children come back, show them that it's healed completely. They don't leave thinking they're damaged goods. We also explain to parents how that's going to heal and how what this has happened will physically not impact sexual or reproductive functioning, because that's where people jump pretty quickly. Mandated reporting we're going to touch on really quickly because mandated reporting is really important. We don't have to prove it. We don't have to know what happened. We just have to have a reasonable suspicion that something is not okay in this child's world. And people say, what if I'm wrong? What if you're right? Is really the more important question. What do? You listen, you gather minimal facts. Don't shut the child down, but you don't really have to do that interrogation or forensic interview. And then we contact law enforcement or CPS, document objectively, and I try to sit in front of my computer screen with the demographic session open because they want all this information. If you don't have it, they may get cranky, but you're still making a report. It can be gathered at some point. What crosses over to where I should make a report, really, it's like in the old days when we did spinal taps. If you thought you needed it, you probably need to just do it. If you think, boy, I think I maybe should report, you need to report. Sometimes nothing happens after a report, and sometimes CPS or law enforcement does go out to the family, but that report still needs to be made if we have concern for sexual abuse. Who do you report to? Law enforcement or CPS? If you're not sure, if you report to one, they will cross-report. We often report to both to make sure that everybody's on the same page early in the process. What about HIPAA? Child abuse trumps HIPAA. And so, but that doesn't mean that we can talk to any about this. We can talk to whomever we make that report. So if I make a report to CPS, I can talk to CPS and law enforcement. Can't talk to the media. Can't talk to other people other than those involved in the care of this child. And so child abuse trumps HIPAA. We can make that report. We can discuss those child's needs in the context of medical care, but we should not be talking to anyone else. We should not be sharing outside those who need to know. What are outcomes for sexual abuse? You can have injuries, but most of those heal. Infection, pregnancy. But the more important and long-lasting outcomes are social. And they depend a lot on what that caregiver is like, what is that caregiver's history, and what is the perpetrator's relationship to the family. Child sexual abuse is also an adverse childhood experience. And so people who've experienced abuse will often have PTSD, mental health symptoms. They have a higher risk of hospitalization for mental illness. Adult survivors are more likely to become victims of violence, including intimate partner violence and sexual assault, develop substance abuse, or repeat victimization. And then there's the health complications that survivors are at increased risk for. There's synergy between sexual abuse and other ACEs. And so what does that mean? It means if you are sexually abused and have another ACE, your risk for complex adult psychopathology is increased. And so for females, sexual abuse combined with intimate partner violence is not additive in its potential effect, but synergistic. If a female has 2 or more ACEs, their risk of long-term mental health problems is very significantly increased compared to what you would expect. For males, the most potent ACE for males is poverty, but if a male comes from an environment of poverty and is sexually abused, the effect of both of those is going to be much greater than if he experienced either one of those alone or something besides poverty as his coexisting ACE. The likelihood of a young man or man getting a teenager pregnant is not zero if you've never been sexually abused, but it does increase significantly the younger you experience sexual abuse. Sexually abused girls are more likely to suffer violence and re-victimization, engage in self-harming behaviors. So when we see children in the office who are cutters, we know that something in their life is not okay. And that's how we start that conversation. When I see that, it tells me you've had some tough times. Tell me about that. That has been a very easy way to segue into that conversation, and it's amazing what children will tell you. Children who are victims of sexual violence, sexual abuse, are much more likely to engage in sexting, to be vulnerable to online solicitation. And that kind of makes sense. There's an article from the Pediatric Academic Society that just came out talking about this. They're desensitized. Their normal bar is put in a different place. But we want these kids to be survivors. We talk to our older victims and say, you know, this is something that has happened to you and it is not okay. It's not your fault. But with help, this will be just that, something that happened to you, not something that defines you. That's not something that is who you are. And so how does that happen? The single most common factor for kids to develop resilience is a stable and committed relationship with an adult caregiver. And so that is critically important. And some children don't have that in their immediate circle. And sometimes it's going to be up to us as providers of care for children to help identify who that adult can be. And sometimes as providers of care to children, we will be part of that unconditional support for that child. What predisposes a child to resilience? You have to have supportive adult-child relationships. Children who have a sense of control of their world are going to be much more resilient. These skills can be developed, but provide opportunities to strengthen adaptive skills and self-regulation, and use the resources around us. Faith, hope, and cultural traditions play a huge role in resilience. Resilience is something that can be developed. Some children seem to just come with it. Other children who look severely affected can be taught resilience skills, and so it's not an all or nothing. And again, these capabilities can be strengthened at any age. Resilience trumps ACEs. We're going to go through this a little bit fast. Talk about prevention. Primary prevention is targeted at the general population. Secondary is at those high-risk individuals and families. Tertiary is directed at children and families in which abuse has already occurred. You get more bang for your buck if you do primary prevention. There's lots of prevention campaigns. The CDC is a great resource to look at ways to approach prevention. when we look at what do we need to do to support families and reduce the incidence of abuse, including sexual abuse, we have to do things that remove risk factors or mitigate risk factors, including strengthening economic supports, help parents understand positive parenting instead of a negative reactive type of parenting. We need to have quality care for children early in life. Those first 3 years, those first 5 years are incredibly important, and some of the misses or damage or omissions that occur can't be repaired if we lose that window of opportunity. Many can, but we know that children oftentimes lose potential that can never be regained if they're not provided an appropriate environment, nurturing environment as a young child. The Enough Abuse campaign is going to be brought to the state of South Dakota over the next couple of years. It is a campaign that really talks about community mobilization and puts a lot of information in youth-serving organizations to help them prevent sexual abuse there, but talks about safe practices for everyone. So if enoughabuse.org is a place to learn about that. The task force that's met for the past 3 years under the auspices of the legislature and the governor has developed a 10-year plan to address child abuse and neglect in South Dakota. And these are the areas that we plan to address. First of all, we have to be able to count things well. We don't have a good way to count things right now. We want to look at health issues. We want to look at mandated reporting. We want to look at law enforcement and child protection responses, public awareness, and really provide an infrastructure through education at the undergraduate and graduate level so that when we have capable responders when this is recognized. The guiding principles are know, respond, and prevent. And it's very exciting. We now have a Center for the Prevention of Child Maltreatment at the University of South Dakota. The director of that department is now housed here on campus, Carrie Sanderson. And it's very exciting because it will be direct actions, it'll be education, things that come out, there'll be research that we'll be able to do. So this will be one of the ways in which child abuse prevention is addressed in South Dakota. Prevention is complicated, multifaceted, but there are some easy steps. If we want to make the biggest impact, we want to do primary prevention. All children need safe, stable, and nurturing environments and relationships. That is the foundation for all primary prevention of child maltreatment of any type. Because if children have that, most of their other risk factors are gone. Where do we begin addressing child sexual abuse? It is a tough topic, but not discussing it, not acknowledging it, doesn't make it go away. And in fact, it does actually run the risk of increasing the incidence by perpetuating ACEs, because we're not addressing ACEs, which are multifactorial, which have epigenetic components. And so we have to talk about this if we want to make a difference. By understanding and acknowledging child sexual abuse, we allow children to disclose in our offices and the adults. And we then allow healing, which is a component of prevention. Albert Einstein said, well, we can't stand by and do nothing. We have to remember that trauma affects parents, and it can affect the way they parent. And so we need to have that ACE conversation in our offices, and it needs to be non-judgmental. We don't need to tally a score. We just need to say there are things that happen in your life that may affect the way you parent. And it's not what's wrong with you, why are you such a crummy parent, but what happened to you? Because sometimes that will change that paradigm for that parent and allow them to see their child and their responses differently. The Gunderson Healthcare System has developed a great approach they're trialing that we're going to follow closely, because we can help protect children from toxic stress if we can impact parenting significantly. What can we do on a day-to-day basis? I would ask all of you who do well child exams to please include a genital exam. I can't tell you how many children come to my office and I say, I'm going to look at your private parts, and the parents are like, huh? nobody ever looks at their private parts in the doctor's office. I'm like, I'm sorry, that's a crime. I don't say that, but so if we are not talking about private parts in the office, number one, we're missing medical conditions that need to be addressed. I can tell you I've found some interesting things. The other thing is, if I'm not looking at a child's private parts, I'm saying they're not important. We don't talk about that here. And so if a child has a concern about anything with their body, we want them to be able to ask that. But the child may also sense that I am too uncomfortable to talk about those things, so I'm not going to look. We also use that opportunity to talk to parents and give both children and parents the understanding that this is important stuff to talk about. We can address misperceptions, acknowledge reality, and prevention steps. We ask parents to talk to their children about real names of body parts. Yes, you can call a nose a schnoz, a honker, but really kids know it's a nose. And so the same thing for a penis. I think vaginas are a little bit difficult because when we talk about vaginas with children, typically we're talking about labia, but we need to acknowledge that this child has private parts and it's okay to say those words. We need to help children to understand the difference between a secret and a surprise. A secret is something that you can always tell your parent, and I don't care who tells you not to tell it. I'm your mom, I am your dad. You can always tell a secret to me, no matter who tells it to you. If somebody says keep a surprise and it's a good thing, that's okay. But help parents teach their children the difference. Help parents understand who's an appropriate caregiver, and help parents to frame helping their children in a way such that I will help you with anything instead of don't let anybody touch you. Because you know what? Kids can't control big people. And sometimes they're touched even when they've been told not to let it happen. And so now that child feels guilty because I wasn't supposed to let it happen. And so, you know, if there's anything that happens to you that makes you anxious or worried or scared or you don't like, if somebody touches you, if somebody hurts you, I will help you. I also used to use that well child exam at kindergarten to help parents understand you can quit helping your child wipe their bottom, because no child ever died of a dirty bottom. But if your child develops good boundaries, that's going to help keep them safe in a long way. Talk to parents about poker face, and don't talk about good touch, bad touch, because sometimes touch that's inappropriate feels good. And so that's confusing to children. Child sexual abuse is an adult problem. We need to deal with it, solve it, and be responsible for it. We don't make kids responsible for their safety in any other arena. Childhood is important, and so we need to let children be children and help them. Question? Sorry, I started slow. Yes.
I've got a couple of questions. First of all, is there any difference in childhood sexual abuse in kids that are, say, in orphanage or in foster care? And secondly, this might be better for an adult psychiatrist, but when it comes to the point where they grow up and have adult opposite sex relationships, there are a huge number of problems from that, like abuse of the other spouse, increased incidence of divorce, etc.
So the first question is, how does growing up in an institution affect a child as far as sexual abuse? It depends. So the risks are sometimes higher. Sometimes the impact can be greater because it depends on what the relationship that child has in that environment. But sometimes those institutions are incredibly caring and giving, and there is that connection for that child. So those children, even if something happens, have a similar opportunity to heal. The risks are a little bit higher, though. As far as adult response to child sexual abuse, without intervention, there is a high risk for fallout, whether it's further violence, further health problems, those kinds of things. And again, some people on the outside can look very normal, but have issues with mental health that do need to be addressed. Yes. You know, that's kind of interesting because they're different but related issues. I think helicopter parents sometimes are so worried about sexual abuse that's part of their helicopter environment. I don't think there's a direct causation, I'm not aware of one, or protection by that helicopter parenting. Again, because some of those helicopter parents are saying, don't let it happen. Or they are so helicoptered that kids feel separated because of the anxiety of that parent. Sometimes it is protective, but I don't think there's any good literature to say that there's an impact either way.
I'm not saying there's a relationship, but I'm just saying that the pressure to be vigilant about this potential for sexual abuse can sometimes result in pathological behavior.
Yes, and that
Lead to not necessarily sexual abuse, but other pathologies.
yeah, and I think it's very interesting. I think we can make tons of parenting mistakes, what I've come to understand, as long as that child knows that they are unconditionally loved and supported. Parenting styles vary tremendously, and we all have baggage from our families, some good, some not so good. But I think helicopter parenting, if it's consistent and done with good intent, I don't know that it's any more or less harmful than other parenting styles.
The epidemiological data that you showed in the presentation, is that limited to the U.S. or is it global data?
Okay, so the National Incidence Study is United States, and globally, I don't know that we have good numbers there because there's not one good counting system, but using various reports from different countries, I think the numbers are similar. In some countries of similar socioeconomic status, I think we actually have higher numbers. But when you look at countries with lower socioeconomic status as a baseline, the incidence is much higher. Then if you include child sexual exploitation, commercial exploitation of children, in some countries those numbers are phenomenally high.
We are out of time. Thank you very much. And if other people have questions,
I'll be here. Thank you.
thank you. Yeah, very good. Good.
Yeah, no, I